Hello, I'm Michael Botticelli, Director of National Drug Control Policy. On behalf of the Obama administration, thank you for your commitment to helping transform our justice system and how we treat individuals with substance use disorders. We know so much more about addiction after years of scientific research. We understand that substance use disorders are diseases of the brain, that they can be chronic and relapsing, but we also know that, like other diseases, they can be prevented, treated, and people can recover. Jails and prisons have the opportunity and responsibility to use every tool to address this disease. Medication-assisted treatment can help stabilize people, keep them in treatment, and ease their transition back to their communities. We all have a role to play in improving the health and safety of our communities and reducing recidivism and rearrest.
I got a lot of friends that have passed away to this disease, and that's what everyone always says. Oh yeah, he was a great kid. Too bad he shot heroin and died. I'm like, I don't want to be that guy. I don't want people. I want people to be like, oh, Matt, he shot heroin until he was 32, but he did something with it. At least he made it. It took a long time. I just know the life of crime don't have a pension. There's no retirement there. That's a lifelong thing. So what am I gonna keep going to jail for the rest of my life? I'm trying to change that. I don't want to keep doing that. I've done that. Been there, done that. I'm good.
When I'm in my addiction, I know that I don't think about all that other stuff. And when I got clean the first time, I didn't have any kids. So I relapsed about 16 months ago. I was clean for almost 4 years. Now that I have her, she was a year old when I relapsed, and she's getting ready to be 3. So it's just, I don't know, like I know that I have her as my security this time, but I also know that that's not, sorry. It's hard to talk about her. I also know that that wasn't enough last time.
31, I don't have anything. I mean, all I have is my family, but I don't have property, I don't have a bank account, I don't have anything. I can't even be a father. It's kind of, I don't know. It's crappy. It's a crappy feeling. I'm just tired of feeling this way.
The brains of people who have progressed into addiction have been changed. They're different. And so they respond differently, and climbing out of addiction is a tremendous struggle.
Sometimes the family does not understand the disease concept, or that their loved one just can't stop using. It's an addiction. And to understand what an addiction is, it's more than just a choice.
We've been calling addiction a disease in this business. We've been calling it a disease since 1956.
I played sports in high school, which is probably the only real reason why I even graduated. My senior year, I blew my shoulder out, and they gave me perks. And I just fell in love with the feeling. So I ate them even after my prescriptions were done. I would show up to practice on all high on perks. I played games on perks, and it would just continued on through my senior year. I did oxys like once or twice, and my friend was like, "Why are you wasting your money on oxys?" He's like, "That shit's way too expensive. I can get you something cheap. It's the same thing." It was heroin. And after that, it was just off to the races.
The stigma around addiction in and of itself, the stigma around the disease of any substance use disorder, the disease of alcoholism, is there, but it's just not there in the layperson. It's there in our medical community. It's there in our health centers. They're not used to dealing with somebody who walks in the door and they're a heroin addict, and they might be high at the time. They're nodding. They certainly have medical problems if they pass. They really don't know how to deal with that, but to call 911.
At its core, addiction is a brain disease. And if we look at another brain disease, for example, schizophrenia, there's no one medication for schizophrenia that works for everybody. So we're glad in mental health to have a lot of different options to try people on. Sometimes something works or doesn't work, and so you go to the next one. Or sometimes something works for a while and then stops working, so you go to another one. So that's true in almost every aspect or branch of medicine. Why would this one be any different?
So the focus on offenders is exciting and important, that now offenders have the opportunities that a lot of other citizens have had to do the medications that support their recovery.
As the Department of Mental Health in Missouri, we've been working closely with the Department of Corrections since 2002 to find ways to reduce offender returns to prison. And so along the way, and this was before there were FDA-approved medications, at least all those that we have right now. So along the way, we saw more and more medications approved for the treatment of addiction. Yet all of us here, I know, are proponents of all of the FDA-approved medications. And when you're talking about someone being out in the community, we believe that people should be able to have access to all those. Not everyone will respond to the injectable naltrexone for a variety of reasons. And so out in the community, if you have someone who's been using heroin heavily for 10 years, the switch to Vivitrol might not make sense. The switch to something else, methadone, Suboxone, might make a lot more sense. The question is always what's more likely to bring someone to recovery. In an institutional setting, they have the drugs, alcohol, whatever, out of their systems. It makes less sense for them to be started on methadone or Suboxone. So again, those products are wonderful out in the community. They work for a lot of people. In institutions, it makes more sense to go to something that is a couple of things. The long-acting naltrexone, the injectable naltrexone, is not psychoactive, so nobody's going to get high. Can't be diverted. It also lasts 30 days, and so that transition from inside prison, where these ladies have developed faith in that product, then out in the community is just that much safer and smoother, because they don't have to deal with, in addition to everything else, they don't have to deal with the cravings, you know, all the negative feelings that go along with addiction.
MATRE is the Medication Assisted Treatment Reentry Initiative. And MATRE was developed in response to the opioid epidemic that was sweeping Massachusetts probably around 18 months ago. So there was a lot of planning, a lot of discussion, lots of interagency discussion that was driven from the Secretary of Public Safety. And when the epidemic crested, we were forced into action to move quicker than we were ready to move. But because we had a lot of the players at the table, we were able to respond accordingly.
Initially, we were approached. Department of Correction was approached by some treatment providers in the community who was saying, hey, let's do this pilot project. We have a pharmaceutical company that's going to give us some free doses to see, okay, can we give this pre-release? And if we give this medication to them pre-release, will that reduce not only recidivism back to criminal patterns, whatever their crime was, but also would it reduce their risk for relapse in the community? So starting off, we only started with 3 male institutions, and we were given 50 doses.
The program initially started with our secretary coming to us and suggesting that we entertain a representative from Alkermes.
We went to the presentation from the drug representative. We were skeptical. It was kind of hard for us to even embrace the idea of using medication-assisted treatment.
We then asked our own director of the Planning, Research, and Statistics Bureau in our agency to do his own research and to tell us all the reasons why we shouldn't use Vivitrol. He did do that. He did the research, got back to us, and said that there was really no reason not to try it.
I was on Suboxones for treatment of opiates, and that actually helped, treat the opiate addiction.
It was hard to to stay with it consistently. I would have to, in all honesty, I would have to have the money for the dose, daily. If sometimes I didn't have it, I'd have to have transportation daily to the clinic, which would be an hour drive. So and I'd have to have gas money and all that. A lot contributed to it. So it was harder to maintain it,
All you have to do is make the conscious decision not to take your pill, and then you can just get high. And I have friends that have sworn up and down about Vivitrol and how good it is and how it takes away the urge. And they all have jobs now. They've been out of trouble forever. So when I got off of it, I just said, I said, don't even finish the sentence. I'll sign up for it right now.
The Vivitrol is a blocker. It's a monthly shot. They don't have to take something every single day. The dangers of that can be that, if somebody were to use an opiate, there is a chance that they could overdose if they're using because they're not going to get that high and they're not going to get that buzz that they would. So that can be a struggle, and that has to be explained to them, and they have to be a good candidate for that.
We had the benefit of having watched and observed Barnstable develop their program, so ultimately we copied a lot of what they did.
I was put in contact with other agencies, other states that had already implemented a protocol for the use of Vivitrol. So I was tasked with creating our own protocol based on information and help I was getting from other areas. It was a big task. I don't think that any of us had an idea of how big it was going to be, because it wasn't just working with the department staff, but we were looking at improving programming within the institutions as well as programming that's received in the community. So we had to reach out to all these different community agencies as well.
You have to have a champion. You have to have a champion at the highest level of your organization.
Getting that buy-in from your top administrators, your top government officials, I think is the most important thing. And then having in place a structure.
Because if it's left to somebody to say this is your goal for next year and they're too low on the org chart, it's not going to be successful, because you need every discipline, security, treatment, management, all these people have to be working towards the common goal.
It cannot be successful unless that they buy into it. And if they don't buy into it, you've got to get another officer who buys into it. And part of it's training too. I think we could enhance the training. We really could enhance the training at the academy level. The old mentality in corrections was the treatment staff against the security staff, butting heads. Nothing gets done like that. So it's important that we work together.
For people who are reluctant, and there are states in which there is a reluctance to pursue medication-assisted treatment. I think I understand, and if in this field there are some clinicians who resist the idea of using medications in treatment because they've been doing these talk therapies for decades. And there's been very little money in this field for decades to purchase medications.
I worked in the drug and alcohol field for many years before joining corrections, and certainly to fix a drug addiction with another drug was not, anything short of methadone maintenance was actually voodoo. I mean, who got clean and sober? They just didn't. I mean, it was about abstinence.
I guess I would say to clinicians who are reluctant that to remember that when psychotropic medications, psychiatric medications first came on the market in the 1900s, one of the groups that was most opposed to psychiatric medications were the psychoanalysts, the original talk therapists. And that's because the use of medications really challenged their whole view of the way the mind works, of human behavior, of who they were and what they were about. That's changed over the years, but it took a long time. I think we're in the same boat with some of our clinicians who are in the substance use disorder field that, it can be threatening. The use of medications can be threatening to them because talk therapy has been their business for so long. What I would say to them is that you need to get over that because these medications are not for everybody, and there's no silver bullet. Every clinician has had someone who has wound up in prison or the hospital or the morgue. These medications for some people will stop that from happening. And so I think we owe that to them as much as we do if my son or my daughter or my sister were in treatment. I would want that person to have access to everything that science says can help them find their way to recovery.
I need to address my problem every week. And if the things I hear about Vivitrol are really good. It takes the craving away, I heard. And why not try it? It might save my life. I mean, this is my third state incarceration. No, I'm only 31.
For me, it was more like a security blanket. I was afraid to go back out into the world without anything because I had been using for so long. I knew that if I was on it, that in my head, I knew that I couldn't get high even if I tried.
And I'm not gonna lie, I tested it, and it works. I felt no head change whatsoever. I mean, obviously, I only tried like a couple beers on it, but I no head change whatsoever.
Vivitrol, it was almost like if a child knows that the stove is hot, he won't touch it. So I had no cravings, no thoughts of using, but once I was off the Vivitrol, the thought returned.
Look, Vivitrol is not, the be-all and end-all, that you really have to incorporate a lot of the social supports and the recovery supports for this to be anywhere near effective and as a protocol for long-term abstinence.
So that meant looking at how do we identify who's appropriate? And one of the things we heard is that you need to make sure you've got the right people at the right time who are willing and committed to their own recovery. So that meant in screening people, we wanted first people who had showed some level of commitment to their recovery while in prison, that they participated in substance abuse treatment in prison. We needed to have a good screening mechanism to determine who was either opioid and or alcohol dependent.
So when an offender is sentenced, they are transferred to MCI Cedar Junction in Walpole, where they are given a battery of assessments, and they would spend anywhere from 3 to 6 months there before they are given a classification hearing, at which time there's a classification tool utilized to determine the best placement for them security level. While they're at the reception center, they are also administered what's called a risk assessment, and the department utilizes a validated evidence-based assessment tool, and that tool will assess for risk of violence and risk to recidivate, and that will, and then once they get to their receiving facility, they will be administered a needs assessment to determine what programming they need throughout their incarceration. Once they arrive at their receiving facility, they'll have a needs assessment administered if they scored moderate to high on their risk assessment, and that has very different scales So if they scored a moderate to high on the anger scale, they would be referred to a violence reduction program, or if they scored moderate to high in substance abuse, they would be referred to a substance abuse program.
Once they pass through the mental health screening, then they're referred on to the clinical side, the medical side, where they actually will see the provider, either a physician or a nurse practitioner or a physician's assistant. And they go through an extensive review and discussion with them about what Vivitrol is, side effects, contraindications, adverse effects, potential drug interactions. They also talk to them about their recovery. Are they a candidate for this? But looking strongly from the clinical side of it and spending quite a bit of time educating them on Vivitrol, what it is, and the effects of it.
I think some of the fears that they have are, one, what's going to happen if they use once they're already on the medication, and that's part of our education process is, explaining to them the possible benefits, the possible risks, so they are informed in making the decision. But also, as kind of a warning to them, we, tell them, you may, if you decide to use and you keep using while you're on the medication, there's a potential for overdose.
I'm here today to talk to you about medication-assisted treatment. My experience with this is here. I work with, setting people up for when they leave. With some medication-assisted treatment if they want it. But also before I came to work here at the jail, I ran the Suboxone program at the Community Health Center at Cape Cod.
And for us, it's appropriate, psychological appropriateness, because we're telling them that we're taking away the substance they've been addicted to for many, many years, and that we're going to give them something that blocks it completely. And so for a lot of people, that's a loss. And if they're not working through that in the community, when they might be going out to areas where they're around their friends who they used to drink and drug with, we're putting them out there, but we've taken that ability to use that substance away.
With the Vivitrol, there are certain requirements. They don't just come in for a monthly shot. They have to be coming in weekly, getting drug screens, seeing an outpatient therapist, and they do have to have their medical care there as well because they want to make sure that they're getting the best possible treatment.
I tried to do it on my own in '97 when I got out, but it just didn't work. So I just one day I just woke up and said I got to do it. I can't come back. I'm too old. It's my fourth sentence. I gave them 26 years, and I'm done. I still do get cravings, but they're not as frequent, I guess. I'd be lying to you and say if I didn't have that feeling that I want to go out and get high or whatever, but. Using the tools that I learned in the program and, doing those steps, it helped me. So, it gives me a minute to step back and think about, the consequences and all that.
Most people are ready to go home. I begged them not to let me go home. I didn't want to go home. I was scared. I knew that once I went home, I was going to be stuck there until I had somebody come get me, and it's always the wrong people that come get you. Even with the medicine, that was my biggest fear, is going home and just being out there again.
Being sober isn't really something that I'm used to. Been using opiates since I was 18, 34 now. Just not used to really doing things, being clean and sober, and basically I know if I go home without something to help me, I might just one day wake up and say, look, I don't want to do this no more. I just want to be on some type of substance. And I don't want to, but that's the reality that can happen.
Approximately 7 to 10 days prior to their discharge, that's when we actually would start them on what we call a naltrexone study of about 1 to 3 days. That's the oral medication of Vivitrol to make sure that they don't have any adverse effect, contraindication. At the day that they're actually going to get their injection, which is about 7 days before they're discharged, they would actually go to what we call our inner perimeter security. They would call them down. They would have a urine drug screen to make sure that there's no alcohol or opiates in their system. And provided that that looks good, they've had no reaction from the oral naltrexone trial, they would then be escorted to the health services unit where they would actually receive their first injection of Vivitrol medication.
And then the external side of it. You can set up the best program behind the walls of a prison, But the research tells you 70% of your treatment effect is what happens in the community. So if we hand somebody off to a community that is unwilling, unable, or unaware, the person's going to fail.
The highest correlate to success and recovery is length of time in treatment. So people who stay in treatment tend to do better than people who don't. For people who leave institutions on medications, in particular Vivitrol, we're finding that they stay in treatment much longer than people who don't.
I got it originally to create like sort of a foundation when I got out, because I think I still had some reservations about getting high. Just getting the shot isn't going to keep you clean. You know what I mean? You gotta want to, but I mean, my cravings went away completely.
Yeah, it do work. And that's what really made me take that shot, because I was like, okay, I've been locked up for 10 months. I know if when I go home, I'm probably gonna be around the same environment for a minute and I might use. So when they was explaining to me what it's for and what it could do, I said, well, I don't want to use, but reality is going to sink in when I walk out these gates. So, yeah, okay, I'll try the shot. So I was agreeable to try it. I started it, I got my first one in February of 2014. And then that's when I got released. And when I came here, I had took maybe 3 or 4 more. And then I just stopped because I felt I didn't need it anymore. And I've been clean for 10 months today.
I think I might need it for a while. I don't think I need to just stop, because I mean, I tried that before and it didn't work. So I definitely, I'm not gonna rush it, you know? So, I mean, if I need to be on it for a long period of time, I'm gonna go ahead and just do it, so.
We serve women who are coming out of prison. Basically, New Beginnings has a contract with the Department of Corrections, and that is called the Out Care Program. These women come from prisons or they're on probation and parole in the community, and they are stipulated to do substance abuse treatment. We stress jobs, we stress boat rehab, we stress education, getting your GED, whatever their client needs to be successful out there, because that's a part of, if they have nothing to do, they're going to go back to drugs and alcohol. We have to work on core issues and deal with things that the drugs and alcohol were medicating.
It opens you up to new ways of life and new ways of thinking about life. Hearing people's testimonies, people like me that have a problem. I'm usually sitting in a room with people that don't have a problem like me.
In the event there isn't a program that helps them to continue to get these shots, then what happens? Because they're very, very expensive shots. This is an extremely expensive drug. And if they don't qualify for governmental help in the form of Medicaid or whatever, then they fall through the cracks.
During the 6 months that they were receiving shots, we didn't have any of the women relapse. I'm aware of at least one who relapsed in month 7, right after she stopped. And she was trying to stay on Vivitrol, but was having a lot of issues with paying for that. After the grant no longer paid for it, we were able to get medical assistance to pay for the medicine, but we couldn't get a doctor who was willing to administer the shot for anything less than $100 for a copay just to come in.
I stopped because the funding ran out, and I relapsed 3 months later.
One thing I would tell anybody that wants to start this program is you need to look at your sustainability. What's going to happen after the funding goes away? How are these people going to function when the treatment is gone?
With some of the relapses that have occurred in months 7, 8, 9, after the people have completed, we want to help bridge that gap more. And there are studies that show that first year is really the most difficult time. And we have started with 6 months because that's even more difficult, of course. But the longer we can help that transition period, the better. And I think that the goal is that we can really bridge those gaps as much as possible and help these folks, be successful.
Now, one of the strengths of our model, we believe, is the use of the navigators. Navigators would work through InReach 90 days prior to discharge to formulate that warm handoff, that rapport, and then they would also schedule the first outpatient appointment with the community-based service provider to ensure that when those folks left, that within almost a day to release, they went and met with either the physician and the substance abuse provider to ensure there was continuity from prison to the community.
I mean, I've been in jail numerous times and never had anyone help me with anything. Like, I always had to have my mother doing it on the street or just get out and try and hit the pavement running and, like, figure it out. But for some reason, this time when Allie offered the Vivitrol shot, it seemed like it came with a lot of help after. Like, a lot of people actually started to care, it seemed like making phone calls for programs, helping me send referrals. And like I said, I got into the Hope House within weeks.
The position starts about 120 to 90 days post-release, so while they're incarcerated, they come up on the radar, they come up on like a list stating that they have an opiate or an alcohol addiction and that they have the option to join a program. And along the way, by the time they get to me, they've said yes, they've taken extra classes, they've taken extra stuff to be involved in the program. At that point, they have been held an information session to be eligible and say, yes, I'm interested. 90 days out to 120 and say, hey, you still interested? Start talking to them about the program, what it looks like for them. While they're incarcerated, it involves finding out where they're going, what their plan is. Are they on probation? Are they on parole? How much longer? How long they've been incarcerated? Where their life has taken them? Like, how did they get where they are? And to find out what their addiction looks like for them.
I fill out the consent form for them to receive Vivitrol. I make sure that their aftercare plan is up to date, make sure they understand all that. And then once the day that they're released, or maybe a couple days before they're released, all that paperwork that I had them fill out, the aftercare, the DC 151, the consent form, getting Vivitrol, the informational consent, I send everything down to the centers that they are going to.
And what the Navigator model did is it built a very strong bridge back to the community, and that community was now saying, okay, we have outpatient appointments, we are now going to continue their treatment, we're not just going to give them a shot, but we're going to ensure they're going to their counseling sessions. So for the first time in my career, and why I think this is a real deal maker, is that we built that bridge in a way that we could never do it in the past, and the navigators are the ones that really anchor these guys coming out of prison into the community.
Out in the community, we've really expanded a great deal on the types of reentry services that we have put together in the last few years, and I think that the Vivitrol program really works hand in hand with a lot of them. So a lot of the men and women who are going to be coming through, and the women who have come through, have housing needs and situations like that, and we actually have programs and monies aside to help people with housing, as far as helping pay rent for the first 6 months and getting people placed in. And so those are not necessarily programs that are Vivitrol specific, but they definitely work really well hand in hand, I think.
So I actually got into a sober living facility, and they gave me up to a year to be there.
My father tells people I live in, oh, he's got his own place now. I was in South Bay. He's like, oh, how's Matt doing? Oh, he's got his own place on the South Shore. I'm like, no, I don't. I have a cell in South Bay. You just don't want to tell people that. That's not cool. My father shouldn't have to lie to tell people where I'm at. He should just be able to like, oh, he's doing good, he's working. Or, yeah, he's at home, or whatever. And my family shouldn't have to lie about where I'm at. And that's what they've been doing their whole lives. I'm not trying to have them do that no more.
I feel like this is an opportunity to help a lot of people. I mean, my sister was concerned with cost-wise, what it's cost to house me off and on all of my adult life, as opposed to paying, $900 a month for the shot.
Every time you're absent for a period of time, you learn something, and you strengthen your resources. So again, I think they did a really nice job of articulating this is sort of a safety net for them, and helps them to build that bridge into recovery, and then ultimately stay there.
I think this medication in combination with treatment gives them a fighting chance at least to stay sober long enough to create some sort of pathway out of prison that will keep them out for good.
And it's been wonderful being in the program right now for me. It's been a big success. Probably the highlight of my career after 32 years of working in corrections has been this program.
And I'm glad, or I'm proud of part of an agency that is forward-thinking about medication assistance recovery programming.
This is not true in most of the rest of the country. Our Department of Corrections was willing to move ahead with this because they were open-minded, certainly not risk-averse, but certainly also very quickly saw the benefits. They're smart, caring people who really care about the people that they serve. And so we started this project probably 2012, where we have offenders who are leaving institutions on medications. And then we are starting to see some real success stories.